Good afternoon, everybody. My name's Rebecca James. I'm a paediatric rheumatologist from Brisbane, Australia, and it's really a delight and a great privilege to be invited to speak today and to be part of this meeting. I'll be talking about when to think of rheumatic disease in children. I'd like to begin my talk by acknowledging the traditional custodians of the land on which we walk, work, talk and live, and acknowledge and pay my respects to Aboriginal and Torres Strait Islanders, elder past, future and present. So to begin with some general tips about recognising rheumatic disease in childhood, the first thing I'd say is beware the child who keeps presenting with musculoskeletal symptoms. So we all know that musculoskeletal presentations, sports injuries, benign nocturnal limb pain, so-called growing pains, are very, very common in childhood. But the child that continues to present over and over again with musculoskeletal symptoms, particularly symptoms that are consistent and persistent, they keep happening and they keep happening in the same place, is really something that should flag some alarm bells for you. And we know that on average, children with juvenile arthritis present something like 9 practitioners before they're ultimately diagnosed. My next tip is that children with rheumatic disease often have remarkably normal pathology. So don't be falsely reassured by the presence of normal inflammatory markers or by a negative rheumatoid factor or a normal CK. Even children that are considerably unwell can often have really quite unremarkable bloods. A consistent theme of this talk will be that malignancy can mimic almost all forms of rheumatic disease in childhood, and that you really do always need to be alert to it, whether that's as a neoplastic or paraneoplastic phenomenon. And something that I've become increasingly aware of over recent years is to consider the nutritional state of any child with multisystem disease. So particularly in Australia, the children that we see with profound nutritional deficiencies are often those on the autism spectrum, and scurvy, for one, can certainly mimic a number of rheumatic diseases very closely, but also concomitant bowel involvement such as inflammatory bowel disease or celiac disease is quite common, overlapping with rheumatic disease in childhood. My next tip is that examination of the hands is often very, very telling. And in fact, I'd go so far as to say you can almost make a diagnosis based on the hands alone for many paediatric rheumatic conditions. So whether that's Gottron's papules in dermatomyositis, Raynaud's phenomenon in connective tissue disorders, sclerodactyly, the pitting, ridging and onycholysis of psoriasis, dactylitis, nail fol capillary changes or absent peripheral pulses in a medium or large vessel vasculitis, there's really a lot to be gleaned peripherally. I would say that there's often a family history of autoimmune disease, but that almost always needs a bit of teasing out. So very often you'll ask the family if they have any autoimmune history and they say no, and then you ask specifically about thyroid, psoriasis, lupus, celiac disease, type 1 diabetes, and very often it turns out that there is more than one family member, but it's not necessarily recognised as autoimmune disease. So you do have to be quite specific on history taking. The trio of fever, rash and arthritis, plus or minus myositis, is obviously highly suggestive of rheumatic disease, but always beware cancer or infection. So the holy trinity of rheumatic disease, infection and malignancy will plague me and all of us throughout our careers, and we must always be vigilant to it. A positive ANA, of course, tweaks the attention of a rheumatologist, but particularly if it's of a high titer, so greater than 1 in 80 in particular, but the higher it goes, the more likely to be pathologic. If there's a suspicious history or examination, so we not infrequently see teenage girls that have an ANA of 1 in even 2560, but without associated symptoms or signs. And of course, if there's other associated positive serology, so antiphospholipid antibodies, double-stranded DNA, ENA, C3, C4. And I guess my final general tip is to look hard for rashes because they're often there, but in hiding. So look behind the ears for psoriasis, along the natal cleft, around the umbilicus, all for psoriasis. The palms and soles can be associated with vasculitis or a pustular disorder, a serratiform disorder. Look at the palate for lupus, at the nail beds for dermatomyositis, lupus and connective tissue disorders, the fingertips, the genitals. So I'll begin my talk by running through some of those rashes. So behind the ears, classic for psoriasis, and under the hairline, or behind the ponytail. So I always take the time to look for these spots in children. There's another classic example behind the ears. They've often been diagnosed as eczema or treated as eczema. Around the umbilicus, the natal cleft, and the genitals are not uncommon for psoriasis. Still's rash, which is the rash of systemic onset arthritis, can be quite variegated, but many cases also have a very typical appearance. And as we all know, it's classically described as the macular salmon pink rash, usually on the limbs and the trunk, but it can occur on the face or the neck. And in particular, I tend to see it on the inner thighs. You can see on this picture just over here that there's very clear dermatographism as well, which is often a feature of Still's rash. And something to look for. Now, the Still's rash, not universally, but often comes and goes with a fever and is almost always more prominent at the time that the child's having their quotidian fever. Here's some more examples of it. And again, and you can really see here this kind of classic inner thigh appearance that is so often present with Still's rash or with systemic onset arthritis rash. So I've got two pictures here. One is on the left, livedo reticularis, and on the right is livedo racemosa, which are very similar in appearance, as you can tell, but livedo reticularis is not always pathologic. It can be physiologic, particularly what we call cutis marmorata, which is physiologic and related to temperature changes. But on the right there, the racemosa, which is very likely to be linked to pathology, including rheumatic disease, so things like antiphospholipid syndrome, polyarteritis nodosa, lupus, dermatomyositis. Now, the differences between them are subtle but real. Racemosa is usually more generalised with a wider distribution and can be found on the trunks and the buttocks as well as peripherally on the limbs. And its lesions are more irregular. So both of them tend to have these quite circular ring-like lesions, but in livedo racemosa, they're often broken rings. And in racemosa, of course, they're persistent, whereas in reticularis, they often come and go with temperature changes. So the malar rash, which we get referred so often. So the top two pictures here are both pretty typical versions of a malar rash, all in young children, though of course they can extend right through adulthood. The malar rash can extend down into what I call the beard distribution, as well as onto the ears and up on the forehead. So even though we call it malar or butterfly rash, that erythema can really extend down around the chin and even onto the neck as well. The bottom picture is physiologic, non-pathologic, so strawberries and cream complexion, and you can really see the sparing of the nasolabial fold is quite sharp in a classic malar rash, whereas it's more of a fading away with that strawberries and cream complexion. Fever, onto our next symptom. So fever and symptom patterns can be really telling in paediatric rheumatic disease because it very often follows a pattern, whatever that pattern may be. So running through a few of the more typical ones: fever at the same time every day with an associated rash, both of which then subside until the next day, is the classic quotidian pattern of systemic onset arthritis. Now, it doesn't have to be every day, day in, day out. Very often these patients will have a day or two when the fever goes away and you invariably discharge them from hospital, but then it comes back again. But it's that idea of a quotidian, daily, persistent fever that doesn't happen all day, every day, like you would see, for example, in Kawasaki disease, but that just keeps coming back. It seems often in the early evening to sort of nag at the patient. A completely different fever pattern, but nonetheless equally telling, is high fevers which last 2 or 3 days at a time that occur with strict periodicity. So it doesn't have to be 21 days, but the patient will often say to you every 21 days, every 26 days, every 28 days, almost to the point where they can mark it on their calendar. We call that clockwork periodicity, and that can be associated with the periodic fever syndromes, but that strict periodicity often goes with PFAPA and sometimes cyclic neutropenia. Rheumatic disease, inflammatory rheumatic disease, often is associated with morning stiffness, so that morning gelling, and whereas biomechanical or growing pains usually get worse in the evening, particularly after a big busy day. Always think of rheumatic disease and malignancy and infection and fever that persists more than 14 days. So the definition of Still's disease is fever that goes on for 14 days. And consider rheumatic disease and fever that keeps coming back as well, that seems to subside but just never quite manages to quell. So I couldn't give a talk on pediatric rheumatic disease without talking about inflammatory markers and making the particular note that many children with rheumatic disease, particularly oligoarticular arthritis, who are also the subgroup that often have the most profound diagnostic delays, often have entirely normal inflammatory markers, and that doesn't at all or in any way preclude a diagnosis of rheumatic disease. In fact, on the flip side, it's somewhat unusual to see triple figure inflammatory markers in rheumatic disease. Obviously, in systemic onset arthritis, which is a highly inflammatory state, or macrophage activation syndrome, we do see it. And this is not a hard and fast rule. But in general, children that have ragingly high inflammatory markers, I would usually think about infection first. I remember when I was in med school and some of my lecturers told me that an ESR was not helpful, or that there was no point in doing it. But as a rheumatologist, I pushed back on that quite profoundly. And you do get a sense based on the pattern of the ESR and the CRP of whether there's likely to be a rheumatic disease versus an infection or something else going on. So if the child has a high CRP alone, that is often, not always, but often an infective cause. If they have a high ESR and a CRP, then that's piqued my interest more. And if they have a high ESR alone, then I'm very interested. And that's classically associated with lupus, a high ESR and a normal CRP. Be mindful that patients that have had IVIG, which many patients with a kind of a nondescript inflammatory condition have, will often have a falsely elevated ESR. So after, for example, IVIG and Kawasaki disease, the ESR becomes unhelpful. So as I nodded to, certain patterns can indicate certain conditions. So lupus classically has a high ESR and a normal CRP, although if they have serositis, arthritis, or infection, the CRP will be elevated in a lupus patient. And if you see a discordance, so a rising CRP but a falling ESR, you must think about macrophage activation syndrome, which is a sepsis-like syndrome. And many a clinician has been falsely reassured by the presence or by the falling ESR, when in fact that's an indicator that things are really going haywire. And finally, we do use serum amyloid as a useful marker, particularly of autoinflammatory syndromes and in monitoring the risk of systemic amyloidosis. So juvenile idiopathic arthritis, going to some specific diagnoses now. I think of JIA when the pain is consistent and persistent. So there's lots of 3 or 4 or 6 or 8-year-olds that complain of knee pain or leg pain, but I get more interested in or more suspicious that it could be arthritis if the pain consistently happens in a joint. So it's very specifically articular pain, and it tends to be the same joints over and over again. Now, of course, there are forms of arthritis that are migratory, classically post-streptococcal. But if we're thinking about juvenile arthritis, it can wax and wane, but it tends not to go away, and it tends to be persistent and consistent in the same joints as a kind of a rough guide. A history of joint swelling as opposed to a history of joint pain is very indicative of inflammatory disease, and would be enough for me as a rheumatologist to triage that referral as a category 1. And asymmetry is a very, very useful sign in clinical examination for rheumatic disease. So looking not just at the appearance of the joint, but also the range of the joint. So I don't have in my head kind of magical numbers of what is and isn't normal range for an elbow or for a knee or for an ankle, because there's so much variability from individual to individual. What I look at is how that compares to the contralateral joint. And of course, it is entirely possible to have, and in fact quite common to have arthritis in bilateral joints, but it would even then, there is usually some degree of asymmetry in swelling, in the range of movement, in the muscle bulk, in the leg length. So asymmetry is a very useful, very objective sign that there's something going on which may be inflammatory. The next thing I would say is that most kids with juvenile arthritis actually continue to function remarkably well. It's very unusual for kids to completely refuse to weight bear when they have juvenile arthritis, as opposed to something like septic arthritis or a structural problem in their hip. Or so if you're seeing a child who refuses to weight bear, have your radar out for differential diagnoses. The one exception I would say to that is children that are in infancy or probably below 2 years, when they're really establishing their mobility, and they will often refuse to weight bear and want to be carried. But children beyond the age of being happily carried by their parents will rarely refuse to weight bear. Rheumatoid factor and anti-CCP antibodies are rarely positive in juvenile arthritis, only 2%, so don't be reassured if your patient has negative rheumatoid factor. And look hard at the fingers and toes for clues. So it's every toddler has got slightly different toes. Every human's got slightly different toes, but toddlers often have sausage-like digits anyway. So I don't look at one foot and then look at the other. I look at big toe to big toe, second toe to second toe, third toe to third toe, comparing one side to the other. Because as you can see in this picture here, this fourth toe could be a normal variant, or it could equally be dactylitis. And if you compare to the other side, you can really get a sense of whether it's likely to be pathologic. There's some psoriatic nail changes. In terms of lupus, particularly have your radar out in adolescent females, particularly those of non-Caucasian background. Take the discordant ESR and CRP, so high ESR, low CRP as a red flag. Look for the fixed malar rash, particularly with that fairly clear nasolabial sparing. Beware lupus in any child with unexplained cytopenias, particularly in an older child, including those who've been diagnosed with ITP. So the adolescent girl outside the classic ITP range who's been suddenly diagnosed with ITP out of the blue, you must check her ANA and serology for things like double-stranded DNA as well as complement. Looking at the palate, the hard palate is a very useful sign in the diagnosis of lupus, looking particularly for injection, ulceration and petechiae, and there will often be signs there that are easily missed but quite pathognomonic. Look for an ANA of 1 in 80 or stronger. The stronger the ANA, the more likely there is to be pathology there. And then with lupus, look for really subtle rashes, particularly to the hands and feet. So that can be flushing, it can be a reticular erythematous vasculitis type rash, particularly to the tips of the fingers and the peripheries of the palms and soles. Nail fold capillary changes, so using a ophthalmoscope, an otoscope, or a capillaroscope to look for things like dilatation, dropout, tortuosity, and you can see some pretty clear pictures of that on Google. Look for Raynaud's and look for arthritis, obviously, in the small joints. So here's some pictures of Raynaud's phenomenon. And then moving on to dermatomyositis. So really interesting condition, which has some once you've seen them, very classic changes, cutaneous changes. But I having met literally hundreds of kids with dermatomyositis, I can think of hardly any that weren't at one stage before their diagnosis was confirmed, told that they had warts or eczema. Very, very classic to be told that Gottron's papules are warts, or that the extensor changes of dermatomyositis, so the erythema over the knees and elbows, is eczema, even though classically eczema is obviously flexural. So look for a malar rash, look for a heliotrope rash, a slightly purplish discoloration over the eyelids, sometimes can look eczematous. Look for Gottron's papules and beware any diagnosis of warts when there's great symmetry. Look for changes over the elbows, the knees, the shawl sign over the upper back, and the V sign over the anterior chest, which are related to sun exposure. It's obviously a photosensitive condition. Clarissa Pilkington, who was head of department at Great Ormond Street when I trained there, had a wonderful, incredibly useful sign that she taught to me and the other trainees, which I call the chin to chest sign. But essentially, if you, for example, over the telephone or in the emergency department are asked to assess a child for dermatomyositis, the most useful thing you can do is lie them down flat on the bed and ask them to to flex their neck. Essentially try to put their chin on their chest, and I'll show you a picture of that in a minute. Because it's very common for children with dermatomyositis to be upright, walking around, going to school, have no reported or observed weakness, and yet they have profound core weakness that is really only picked up if you specifically look for it. And that, for me, particularly if you're getting a telephone call about a kid that's got rashes or whatever symptoms and you think might be dermatomyositis, get them to lie them down flat on the bed and see if they can lift their head up. And if they can't, then be very suspicious of JDM or some other proximal myopathy. The other thing to say about JDM is that they very often have normal CK or only slightly elevated CK. So they tend not to have the ragingly high CK in the many thousands that you sometimes see in more adult disease. Often in the hundreds, sometimes in the low thousands. They can be higher, but I would be very suspicious of a child, and I would be very comprehensive in my workup if a child had a CK in the many, many thousands. And likewise, a child that has a normal CK can absolutely have JDM. Watch for AST and LDH. There's often subtle changes in those other muscle enzymes as well. And the other sign that can be useful, which you can see a little bit in this picture here, is what Clarissa Pilkington called raggedy cuticles. So in addition to the very subtle nail fold capillary changes, they have this cuticular overgrowth from the hyperemia, so the increased blood supply, and they just have raggedy kind of excoriated cuticles. So this is, I think this is probably Pilates handout or something similar, but it essentially demonstrates what I was talking about in the chin to chest sign. So you get the patient to lie down flat, and then you ask them to put their chin on their chest, and then try and put some resistance against it if they're able to do that. And children with dermatomyositis almost invariably are either unable to do that or unable to hold their neck up against resistance. So a quick Cook's tour of vasculitis. Of course, there's classic labs that we look for in vasculitis: ANA, dsDNA, ENA, C3, C4, and antiphospholipid antibodies for lupus. ANCA, both immunofluorescence and also MPO and PR3, if you're thinking about ANCA vasculitis. HLA-B51 can be useful in Behçet's, though is not by any means always positive. Anti-GBM antibodies, glomerular basement membrane for Goodpasture syndrome. And always think of vasculitis as possibly a para-infectious or post-infectious phenomenon, including, of course, what we've seen over the last 2 or 3 years, which is MIS-C or PIMS-TS following on from COVID. Always check the renal sediment for activity, so blood cells, protein. And think about vasculitis in any patient where there's unexplained fever despite extensive investigations. If there's unexplained multi-system disease, of course, the vascular trunk extends throughout the body by necessity. If there's unexplained elevation in inflammatory markers, and particularly look at the blood pressure. And if you're seeing that kind of picture, always be sure to check the pulses, listen for bruits for Takayasu arteritis. So I've seen a number of patients in whom the presenting symptom is really very non-specific, so either fever of unknown origin with nothing else to find on examination, back pain and generalized malaise, but nothing much to find on examination. And you really need to, in these kids that seem to be hot and inflamed and you just can't pinpoint what it is, you really need to have Takayasu or a medium large vessel vasculitis on your radar. And of course, in the presence of mouth or genital ulcers, you must think of Behçet's. So this was a teenager that I was referred with biomechanical back pain, or back pain presumed biomechanical, who had no fever at all, but on probing, she had persistently raised, moderately raised inflammatory markers, ESR of 30-ish and CRP about 50, but she was hypertensive. And as you can see, when we did the angiography, she had this beating and stenosis, and she ended up having very significant aortic changes as part of her Takayasu arteritis, which is what accounted for her supposedly biomechanical back pain. So finally, when to think of something else? What are the red flags in paediatric rheumatic disease? So consider when there's non-articular pain, particularly bone pain, by which I generally mean diaphyseal pain. Consider when there's fever without raised inflammatory markers. That to me is always a red flag for malignancy. If there's raised LDH, or if there's loss of weight, again, concern about malignancy. Pay attention to the blood count, particularly look for bicytopenia or pancytopenia, and look for an inflamed child, high SR, high CRP, but with normal platelets, which we would call a relative thrombocytopenia. And that can be a sign of malignancy, for example, a leukemia, when the child is inflamed from their malignancy and would normally have a thrombocytopenia, but in the presence of systemic inflammation, it pushes their platelets up into the normal range. Of course, beware night pain, and beware very severe pain, a child who's unable to walk, who's stopped walking. Most kids with rheumatic disease actually function pretty well. Beware monoarticular disease. Many kids, probably most kids that present with juvenile arthritis have monoarticular disease, but have unilateral disease. But if it's monoarticular disease and there's a single joint, yes, absolutely, it can still be juvenile arthritis, but just be very sure that you've ruled out structural stuff first. Look for infection, malignancy, Perthes, Sufis, PVNS, so pigmented villonodular synovitis. So if it's only in one joint, imaging is really important to make sure that you've excluded other factors, other potential contributing causes. And here's a classic X-ray of a SUFI, slipped upper femoral epiphysis, and the so-called ice cream on cone. And for SUFIs, of course, don't forget to do the frog leg view x-rays, otherwise you can miss it. So in summary, when to think of rheumatic disease in childhood. Probe the family history of autoimmunity and do be quite specific. Always be more suspicious in female patients, particularly adolescent patients and those of non-Caucasian backgrounds. Be alert to symptoms that are persistent and consistent. They keep happening over weeks to months, always in the same spot. Be alert to morning symptoms, to asymmetric symptoms, and to the triad of fever, rash, and arthritis. And of course, in any child where there's unexplained and persistent inflammation or fevers or multi-system disease. So thank you very much again to the organisers for the opportunity to present today. I really am very grateful, and I thank you all for your time. If you have any questions or feedback, I would very much welcome them. And it's rebecca.james2@health.qld.gov.au. So thank you very much.